Good afternoon, everyone. I'm Mark McClellan. I'm the director of the Duke-Margolis Institute for Health Policy, and I am really pleased to welcome everyone here with us in person and online for this afternoon's event on advancing whole person care for all through North Carolina's State Transformation Collaborative.
North Carolina Department of Health and Human Services, our mission is to improve access to whole person health care across the state with the goal to create a healthier North Carolina for the more than 11 million people who live and work here. DHHS is excited to have signed the alignment proposal along with the 30 plus other organizations we were on there in the state to improve population health, enhance the patient experience, reduce healthcare costs, and decrease administrative demands on healthcare providers. And as a person who did primary care for 31 years, I say thank you on the burden reduction. It's long overdue. This proposal is the culmination of over 2 years of multi-stakeholder collaboration and hard work across health plans, healthcare provider groups, clinically integrated networks, health systems, employers, CBOs, and state entities, including my own and the HIEA. Together, our priority to advance health by increasing opportunity and outcomes for people who face greater health and situational challenges across the state can be bold. The STC's efforts to reduce provider administrative burden can also support a broader pathway towards value-based payment that the Division of Health Benefits or the Medicaid program has been spearheading. If we can reduce administrative burden and make critical data more readily available for providers, especially those providers caring for patients in rural and underserved areas, we can support greater participation in value-based payment schemes throughout the state and focus our resources on investing in health rather than in healthcare services. The Transformation Collaborative is a valuable resource for bringing people together so we can all collectively focus on improving health and well-being in our state. In partnering with the Duke-Margolis Center to lead the State Transformation Collaborative, DHHS adds momentum to the STC's effort to leverage cross-sector stakeholder engagement and to contribute to the common mission to advance high-quality, whole-person care for all 11 million North Carolinians. While we may be experiencing a shifting landscape, these headwinds remind us that collaboration is critical, and we need partnerships like those fostered by the State Transformation Collaborative. During these uncertain times, the state can play a role by continuing to do the important work of bringing multi-stakeholder groups together, not only to establish our goals, but to remain focused on these priorities and to further our collective efforts to find the bright spots and build on these successes and ultimately strengthen the healthcare system across our state.
We also see similar investments in value-based care and whole person care in the commercial sector in our state. And these approaches really appeal to payers, providers, and other stakeholders alike because of the flexibility to design care models to really meet the needs of patients and families. But North Carolina healthcare leaders need help streamlining how all these different health reform programs are being implemented, really to support the healthcare and social service system's capacity to provide whole person care. Reduce time spent by providers on administrative tasks, as Dr. Greenblatt was outlining, so they can really focus on caring for patients. And finally, measuring the state's progress toward meeting its health reform goals. Multi-stakeholder alignment on the components of payment models on things like performance measures and data sharing can make it easier for provider organizations to adopt value-based care arrangements. But getting to agreement on some of those practical steps to achieve alignment is a significant undertaking when stakeholders have varying approaches to how their organizations work toward their own strategic goals. But just wanted to underscore the specific alignment steps that we are proposing within each of these action areas, again, meant to be responsive to where organizations are, those that are, we talk a lot about kind of those that are ready to drive on the highway for data sharing and go 70 miles an hour, and organizations who maybe need to stay on a frontage road for a little bit, but that want to track on to the highway as well. And so how can we develop alignment opportunities to respond to the varying resources and capabilities that organizations can bring to bear in these spaces.
So the saying is, if you're not at the table, then you're on the menu. And representing one of the Medicaid prepaid health plans, obviously we want to be at the table, right? We don't want to be on the menu. We are frequently on the menu, but that's okay. But no, the opportunity to be at the table and to hear the discussions, to be able to get the multi-stakeholder input into quality measures, value-based care constructs, how we can address provider concerns was certainly a key consideration for us. North Carolina has always been just so far ahead. I frequently will hear from our friends at the enterprise level saying, how do you guys do this in North Carolina? What are you hearing in North Carolina? Because they're expecting that they're gonna hear and see that coming nationally as well. And so the ability to take what I've heard from my colleagues as part of the STC work and reflect that to our friends at the enterprise level and shape what we're doing there has also been incredibly valuable.
The STC has really just provided an opportunity for us to discuss very candidly the difficult things that we're all dealing with, from quality measures to exchanging health-related social needs data, and is just directly aligned with what we're trying to build at the Health Information Exchange Authority.
Value-based care, value-based payment models, whole person care, to me, is just simply what we should be doing. So the opportunity to normalize that in North Carolina as our common future and goal, we can't pass that up. So to your point, we wanted to be in the room at the table. This gave, from a health system standpoint, when during times of financial instability or fiscal uncertainty, we often tend to focus on the near term. And we make sometimes myopic decisions. And this gave a venue for us to really keep the focus on the future and keep the momentum going. And to me, collaboration and collaboratives like this are critically important because all stakeholders matter. It's much easier for me to understand someone else's perspective if I'm at the table talking about what the barriers are collectively, individually, and then creating a path forward and finding those windows of opportunity where they overlap and jumping right through.
So you had CMS, you had commercial and Medicaid and, Medicare essentially there. You had different types of provider groups, all different stripes. You had the state leadership, and the secretary really came in and laid down the gauntlet and said, I want you all to get something done. And so it just seemed, I think for all of us, a really unique opportunity to move the ball down the road.
Working on this, I think the STC has been a great venue for us to sort of chat about what progress we've made to date, share those lessons learned, and then also hear about what work is going on in the other spaces that we might not be as in tune to, and see how we can collaborate across different agencies. I think we've walked away from plenty of the STC meetings and work groups sort of with a action plan to collaborate with different agencies and bring other folks to the table. So overall, I think it's just been the venue for being able to have these conversations that sometimes happen in these siloed spaces.
This way that if there's a river and you have 100 people that come up to this river, everyone's going to jump in and try and swim across, and they're just going to figure out how to do it. But if you lay down a bridge, suddenly you don't have to worry about getting over the river by yourself. You can focus on everything that happens before you even get there. And that's what this feels like. And so when we have standardized screening, standardized connecting systems, suddenly we can stop paying a lot of attention to the how, and we can focus more on what the data is telling us. And how we can connect the right resources.
So what I'm not, Duke-Margolis is in that role now, but there's something about the human element of us connecting in this neutral space to advance some, really important policy initiatives around, for us, the survival of primary care. That value-based care is no longer a side hustle. It's central to the survival of independent practices that are critical for the infrastructure in North Carolina. So
the role of you all being a convener is just critically important. It's how we understand each other's perspectives. That's how we get over barriers.
I would say that I think moving into the future, this is only going to become more important, this forum, to be able to continue testing on these different strategies we've identified, test that bridge, make sure it's strong. If not, come back and, it's part of the quality improvement process, being able to talk about what's working and what's not working and how can we move forward. So I'm just really excited for the future. I think we've laid such a strong foundation. It's only going to help us moving forward.
To it, I think I see it along the same vein, democratizing the work of this collaborative and making sure that these great ideas do not stay in this room, don't stay within the walls of the collaborative, right? But making sure that it is applicable, is relevant, is meaningful to the field across the state. So that is really our great opportunity, is to sort of making sure that we are aligning outside of the walls of the collaborative. That's very important for me, and just making sure that we're translating these ideas in our identified priorities in a collaborative way that reaches all corners of the state, right? All different types of providers, types of provider types. I really think that that is our opportunity at this point.
And so when thinking about the FTC and the, as Jess called it, the circle of trust, that's already here, right? It's like the type of partnership between public health and healthcare. They're going to be so critical, because I don't think I have to convince anyone in this room that that partnership is so incredibly important. We're interwoven threads, and you pull on one and both, the other is weakened, and instability and performance in all the ways. I think, coming back to that circle of trust and thinking about how in this moment, with a lot of uncertainty and cuts proposed on many sides of the health ecosystem, not to forget about that public health front, and how there's just going to be these ripple effects, and how the FTC can really be part of the solutioning because of the collaboration.
Is around prior authorization. So CMS last year finalized a rule that for regulated payers, folks, payers we regulate, MA plans, CHIP, et cetera, requires a bunch of new processes around how they interact with prior auth, especially from a data and standards perspective, trying to improve transmission and workflow around that. So some examples. The second policy initiative I think worth highlighting is that we've spent a lot of time and done a lot of work to improve access to data, especially administrative claims data. So that same final rule I mentioned before also includes new provisions expanding patient access to their claims data, as well as provider access to data. So, and the third policy initiative to highlight, also very recent, CMS recently published an RFI seeking public input on how to advance a secure, interoperable, seamless, patient-centered digital health infrastructure. This RFI, the first is to build a national healthcare directory. So providers first, a single source of truth for provider data. The fourth was expanding access to another one of our APIs called Data at the Point of Care, which gives providers access to their claims data.
When we think about things like the FTC and data, is there's no shortage of data in healthcare. And there's no shortage of brilliant people. There's a lot of shortage and agreement and consensus on what is the right answer with data and what is something we could all agree to. So while we're having long-term policy debates, we're doing some short-term action that generates some gains and some momentum going forward. So I think the policy discussion is good and important, and we're happy to participate and offer data and suggestions. But also I think the key pieces of going forward is how do we move things a little bit forward so folks have a little bit better access to care, and just be okay with we're not going to get it perfect tomorrow, but as long as we're moving in the direction of better, I think that is spiritually where we need to be.
Highlighting. So I think that this is there's a real opportunity to bring in patients more into this transparent infrastructure that allows them to engage in data. I think prior auth is a good example of that. So a big part of
make decisions around the data that we have. How accessible is it for a provider, a payer, a healthcare system to have that data again, so these patients are not burdened with repeating the same information over and over, right? And how can I make sure that the providers that I see have access to the information that they need to be able to make the decisions, and again, that's.
So I just want to make that call to action for if there's a way for the STC to really be a leader in this space with the continued disparities we see in maternal teams. And so I think another area where the FTC can really bring the collaboration in the same way that I'm working with some groups nationally that are trying to do this collaboration, or to ensure three things. One, we need to be able to ensure that payers are still paying for vaccines. Two, that healthcare clinicians, provider systems are still ordering and offering vaccines. And then three, that patients and people who want the vaccines can get them.
So, help us think through a roadmap of starting. And just know that we're not afraid to, we're not going to solve every problem all at once, but we got to make some forward momentum. And I think that will help the SDC get more funding and get more support and get more resources. Like, how can you help us log small wins on big problems? I think is the next best step forward. So how do we, people can't take care of themselves if they can't go see their doctor again. So how do we manufacture that
And, you know,
access?
how again,
And I-
can we work with stakeholders and partners to remove some of those barriers by, you know, supporting the workforce, updating our policies and understanding, you know, where some of our public health colleagues that can lean in from their vantage
For it,
points.
you know, maybe those are concentrated pilots and testing things out, but I think the intent here is to be very much multi-stakeholder, multi-payer.
pillars.
We are all
The first is promoting evidence-based prevention, and I'll talk a little bit more about that, but just to say the other two, it is driving choice and competition and empowering patients to reach their health goals. So just to say it clearly, we are focused on what is traditional primary and secondary prevention, screening for, preventing diseases, but very focused also on what is called tertiary prevention, really the importance of addressing the chronic disease, which is prevalent in the populations we serve, and managing and trying to slow the progression of those diseases. And we see an opportunity to really strengthen our approach to prevention by emphasizing opportunities for payment reform to drive better nutrition and lifestyle changes and physical activity. And so that's the focus of our prevention pillar right now. Is that if we give people usable data, they can better understand their health status, interact with their providers, make good choices about their health. And they may be able to also, we're also thinking about patient-facing apps that create transparency around the choices they have of what providers they go to.
And,
So both of those.
you know, our state transformation collaborative here was actually born out of a CMMI pilot previously with 3 other states around advancing these public-private collaboration. That was always intended as kind of a temporary launch support with the idea of, you know, transitioning to a more sustainable model. With the new administration, that's happened. It's good to see that our work is continuing.
Well, and
but,
so it's no surprise that the LAN is launching 4 new initiatives. 3 of those initiatives are aligned with the pillars of that CMI has outlined. So that includes prevention, evidence-based prevention. That includes driving market competition. It also includes patient empowerment. But in the most recent months, we've really been focusing a lot on how we can leverage technology and really drive a technology-enabled ecosystem across the country.
Right, there's a lot of pieces of evidence, but I think what we really want to try to do is figure out in all of our models, what are the different ways that we can embed flexibilities, payment changes, provider incentives, direct incentives for beneficiaries, connections to community providers. Where can technology help folks access, you know, asynchronous support? How can we use technology to help beneficiaries with, you know, nudges towards different things? And where do we bring more support for providers to connect with evidence-based practices that are in the community?
You say, what can we do here? Let's really talk about what it would take to equalize patients, giving them information and having them part of their own care team, having them be able to have conversations. And that does mean alignment and quality measures, but it means thinking about quality measures that matter most to patients, and then being able to use that, leverage that information for wellness plans and for treatment plans.
Right? On the one hand, we're really still working at CMS to kind of align and reduce the number of measures, right? I think it took some time, but we've actually had some good impact of the work called the Universal Foundation that really first came out a couple of years ago, where we said, here's a core set of primary care measures. And then it takes, you know, rulemaking and engagement and whatever, but now almost all of the CMS programs have centered on that set of measures. And turns out, I think North Carolina is thinking about some very similar measures, right? So they're
certainly been watching closely.
yeah, and you know, payers and I believe the land weighed in to help us decide on that set. So it's been bi-directional, but it's slow. But there is progress towards sort of this decreased burden